Welcome to Nursing 150 Module 3. Nursing 150 Module 3 is going to address management of patients with problems of the gastrointestinal system. This presentation will focus on care of the patient with upper gastrointestinal disorders. Before we proceed, it is important to kind of review assessment of the gastrointestinal system. And reviewing that, you should review the anatomy and physiology of the gastrointestinal system. It's important to be familiar with the terms that we're going to talk about, such as esophagus, stomach, the oral cavity, all of those pieces of the upper gastrointestinal disorders. So if you're unfamiliar with that, it's a good idea to review that before you proceed with this presentation. The first disorder that we're going to discuss is the gastroesophageal reflux disease. It's something you may have heard of. It is the most common upper GI disorder in the United States. It occurs most often in the middle-aged and older adults, but can affect people of any age. Usually, gastroesophageal reflux disease occurs as a result of backward flow of stomach contents into the esophagus. So if you reviewed your anatomy and physiology of your upper GI system, you know that you have a patient who has this esophagus. If this is a patient's face, it's not a very good drawing, but you have the throat where they swallow their food and it goes into the esophagus that leads into the stomach. So it's important to consider that the gastrointestinal tract is meant to be a forward flow of what we take in, to flow forward through the body. We absorb what the body needs, and then the rest of that is, of course, excreted through the large intestine and excreted out of the body. Gastroesophageal reflux disease is when the contents that reaches the stomach kind of backflows, and that can cause a problem. And that can cause irritation and corrosive damage to the esophagus. What typically works to make sure that what we take in here flows forward through the gastrointestinal system are sphincters. So there's one here that closes as the esophagus flows food through. There's a sphincter that closes and keeps the whatever's in the stomach from coming back up. Sometimes these sphincters do not work adequately, and so it allows for some backflow of the stomach content, which is very acidic, and it causes damage to the esophagus, which results in gastroesophageal reflux. So the important thing to remember is that gastroesophageal reflux is caused by inadequate sphincters that allow the backflow of the stomach content, and it's a pressure thing. So if there's a lot of pressure from the stomach being placed on that sphincter, it will cause a backflow. So it's pressure and inadequate sphincter usage. So those are the causes. There are risk factors that make this happen, but they're not the causes. So we'll look at that in the next slide. So here are those risk factors. Obesity. H. pylori is a bacteria that causes just a dysfunction of the stomach content. Hhiatal hernia, which we'll explore a little bit more in the next few slides. Pregnancy, wearing tight clothing, and ascites. So ascites is fluid in the stomach. So if you think about what I just said, I said pressure on that esophageal sphincter. It's the lower esophageal sphincter. That pressure placed on it makes it kind of open, and so it allows for backflow. So obesity, think about if you have a lot of weight down here, the pressure of that pushes upward. So obesity, pregnancy, wearing tight clothing, and ascites are high risk factors for causing that increased pressure that causes that inadequate function of the lower esophageal sphincter. So those are major things that causes GERD in most patients. Okay, looking at the most common cause of GERD, it's excessive relaxation of the lower esophageal sphincter. It allows the reflux of gastric contents into the esophagus and the exposure of esophageal mucosa to acidic gastric contents. So it starts to kind of break down the mucosa of the esophagus and cause damage. Patients who are overweight or obese are at higher risk. If you review the anatomy and physiology of the GI system, you know that the stomach naturally has a very acidic environment to break down the foods that we take in. The esophagus is not equipped to be able to tolerate that high of acid. So that's what begins to break down the mucosa of the esophagus and causes these symptoms, these key features that are listed here. The dyspepsia, or the feelings of indigestion, that heartburn feeling. Regurgitation, so that means where it's kind of that backflow of that burning. Coughing, hoarseness, or wheezing at night. Think about this. We said that it's the pressure pushing on that lower esophageal sphincter. So think if you lay flat, that pressure is pushing up through that sphincter. So it's about gravity kind of in that situation. So when the patient may have to sit with their head up at night to prevent this from happening. But the coughing and the hoarseness is caused by that the acidity of the stomach content that's kind of coming back up, hitting them in the back of the throat and irritating them. This is just a picture for you visual learners can see a stomach here with its very acidic environment. In a healthy patient, you see how the sphincter closes and prevents the backflow of that. This is your patient with GERD who there's allowing a little bit of backflow of that acidic stomach content to cause irritation that causes all those signs and symptoms, key features that you just saw in the last slide. There is no definitive diagnostic test to diagnose GERD. It's typically just if a patient presents with the signs and symptoms, we will go forward and go ahead and treat them with some lifestyle changes. That typically can be a major factor. Lifestyle changes and then possibility of some medications that are appropriate. Non-pharmacological interventions is lifestyle changes such as nutrition therapy that can relieve the symptoms. With relatively mild GERD, so small, frequent meals are better than large meals. And if you think about the cause of GERD, a small meal would cause less pressure on that lower esophageal sphincter than like eating giant meals. So small, frequent meals are helpful. Avoidance of irritating foods that irritate and cause that higher acidity in the stomach content. So foods that can be more irritating is chocolate, peppermint, fatty foods, alcohol, caffeine, carbonated beverages. They should restrict spicy and acidic foods. So basically, those things, I want to make it pretty clear, those are not the things that cause GERD, but they can irritate it because they make that stomach content more acidic. So if there is a reflux of the stomach content, then it will be much more irritating and the patient will be more symptomatic. Like I said, large meals increase the volume and the pressure in the stomach. Remind the patient to eat 4 to 6 small meals a day. Encourage patients to avoid eating at least 3 hours before going to bed. Because again, it's that pressure. If they eat a huge meal and then go to bed, there's going to be a lot of pressure when they lay flat against that lower esophageal sphincter, causing discomfort. Obesity, if a patient is overweight, losing weight simply could be helpful in preventing the signs and symptoms of GERD. So as stated in this slide here, it talks about the non-pharmacological treatment for GERD is to relieve the symptoms, treat esophagitis. For most patients, GERD can be controlled with nutrition and lifestyle changes. That's where we go first. If we can make those lifestyle changes and relieve the symptoms, then we're done. Some patients, this is not, maybe they're not able to maintain the lifestyle changes, and it's not effective. So that's when we might aim for some drug therapy. And there's 3 major types included in this: the antacids, histamine blockers, and proton pump inhibitors. Antacids typically help because they elevate the pH level of the gastric contents, making it more alkaline, so it's not quite as irritating. Sometimes the patient can just get by with doing some antacids. Sometimes when a patient has a little bit more frequent symptoms of GERD, then they might have to go on to the histamine blockers. These medications reduce gastric acid secretion, they improve symptoms, and promote healing of inflamed esophageal tissue. These are available over the counter. They're widely advertised for heartburn, so they're pretty effective. They're pretty safe medications to take. They are long-acting, they have few side effects, and allow less frequent dosing. Examples of these medications are cimetidine, famotidine, and ranitidine. Notice they have similar endings, so it's helpful in remembering the names of these medications. Proton pump inhibitors suppress gastric acid secretion. They are typically saved for treating patients with active ulcer disease or erosive esophagitis, so they're typically reserved for a little bit more serious condition than just your average or occasional indigestion. So we'll talk about those a lot more when we talk about ulcers and a little bit more serious stomach and esophageal problems. So the definition of the hiatal hernia is the protrusion of the stomach through the esophageal of the diaphragm into the chest. So basically the stomach kind of protrudes up through the diaphragm up onto the esophagus, causing similar symptoms as GERD does. It's an irritation down there, the lower portion of the esophagus. And the pictures in the next slide are a little bit easier to help explain it. So this picture kind of shows here, over here on this hiatal hernia side, this is the normal way that the diaphragm sits, and then the stomach sits below the diaphragm. This is the lower esophageal sphincter here. So you can see the portion of the stomach has kind of come up through the diaphragm, and so now it's sitting up above the diaphragm and getting kind of squeezed off, and so this causes very similar symptoms as GERD. So sometimes they're treated very similarly. This type of a hiatal hernia can typically be treated with some of the similar lifestyle changes and medications as GERD. Because again, it's kind of common stuff. You've got your stomach coming up through here, and some of that stomach content gets upward through there. So it causes some of the same symptoms and can be treated very, very similarly. There are a few more serious hiatal hernias, and the rolling hiatal hernias where there's a much larger portion of the stomach that herniates up through the diaphragm, and that requires a little bit more surgical intervention. But for the most part, hiatal hernias can be treated very similar as GERD can, with lifestyle changes and the same medication. It's important to mention at this point, as we're talking about esophageal problems, that at times people can have a difficult time differentiating between having heartburn and chest pain, which could be associated with cardiac issues. We know that cardiac issues are very life-threatening, so if someone comes in talking that they have pressure in their chest area, we will often, actually always, rule out any cardiac problem that's causing that pressure in their chest. Can you imagine, just talking about that stomach protruding up through the esophagus, it can cause some of the similar symptoms like that pressure in your chest as a cardiac problem might do. So we always have to rule that out. Once we rule out it's cardiac, then we will investigate further that it could be a GI problem. So a very extensive history is important in helping us differentiate if it's a hiatal hernia or not. The barium swallow study with fluoroscopy is the most specific diagnostic test for identifying a hiatal hernia. So sometimes it's hard to tell. Like I said, sometimes it can be confused for cardiac pain. Sometimes they'll be treated for thinking that the patient might just have some GERD. It's when the patient continues to have symptoms after treatment for GERD, after lifestyle changes, maybe put them on a histamine blocker and it's not effective. Then we would probably order the barium swallow with fluoro to help us make a more definitive diagnosis of a hiatal hernia. And basically, a barium swallow is when a patient actually drinks a contrast called barium, and as the barium goes down through the esophageal tract, we will take pictures of them under fluoroscopy. So it's helpful in us looking at the anatomy of the patient's GI tract to determine whether there is indeed a hiatal hernia, whether the stomach is coming back up through the diaphragm. So it's a very helpful tool. The only time this would be contraindicated is if the patient is for some reason unable to swallow the barium, if they can't, if they have any difficulty swallowing or anything. It's important post-procedure to make sure that the patient does pass the barium. It can make their stool a funny color. It can make it gray colored. So it's important to increase fluids to make sure that they pass the barium out of their body and make sure, because it can cause constipation, but we do want them to be able to get that out of their body, so we will increase fluids. And sometimes they will prescribe a laxative just to make sure that they do pass the barium. It will cause, again, it's good to educate your patient that the stools will appear chalky white because the barium. And it's important to have them monitor that they do pass it because barium can cause constipation and maybe a bowel obstruction. So laxative and increased fluids can help prevent that. So the medical treatment for a hiatal hernia is very similar to that for the patient with GERD. We do the same lifestyle changes. Drug therapy would include the antacids, proton pump inhibitor, such as Prevacid lansoprazole or omeprazole. Sorry, gotta say those right. An attempt to control the reflux and its symptoms. Nutrition therapy is important, and it's just the same thing as for GERD, to avoid caffeinated things, to avoid foods that are irritating, such as spicy foods or caffeine or chocolate or peppermint. So that is medical treatment. Surgical management may be indicated if the hiatal hernia is more severe. Surgical management we'll discuss in the next slide. The laparoscopic Nissen fundoplication is a minimally invasive surgery that can be used for the repair of a hiatal hernia. They are post-operatively after this procedure, they are at risk for some of the common things post-procedure, such as bleeding and infection. Also, interventions post-operatively, such as elevating the head of the bed to lower the diaphragm, to make, of course, to not put pressure on the area where they just did the repair. Making sure you monitor for bleeding, pain, help the patient out of bed, help them to cough and deep breathe. Sometimes when you have a little bit of abdominal pain, it's hard to do a lot of deep breathing, so it's helpful if we help them to be compliant with that. There are a couple of tables in your book that are very helpful in understanding patient and family education for after this procedure and best practice for patient safety and quality care, assessment of post-operative complications related to fundoplication procedures. Patient may have temporary dysphagia, so they may have difficulty swallowing for the first 24 hours afterwards, so it's important to make sure that they're not getting choked and that they are getting some intake. They might have some bloating, belching, distension due to the procedure itself, so monitoring for that and treating it if possible. So a lot of it's similar to what you would do with most patients post-operatively, but you are managing their GI tract because we've been in there and manipulated the GI tract, so it's important to kind of monitor that. Monitor for the return of bowel sounds. If there's an NG tube hooked up to suction, it's important to understand how to manage a patient with an NG tube. That's checking placement, checking the secretions that are coming out, checking patency, making sure that that's not irritating their nose, things like that. So lots of things to think about post-procedure. So we're going to move on to talking about disorders of the stomach. The first disorder we'll discuss is gastritis, which is inflammation of the gastric mucosa, or the lining of the stomach. And we've probably all had a little case of gastritis. This is when we get an upset stomach, typically related to something we have put into our body or something that is just kind of not agreed with us. This is typically referred to as an acute gastritis. So it's your average stomach upset due to food poisoning. It's typically acute gastritis is caused by ingestion of food contaminated with disease-causing microorganisms or food that is irritating or too highly seasoned. Overuse of NSAIDs and aspirin can also cause an acute gastritis. Excessive alcohol intake or reflux can cause an acute gastritis. Chronic gastritis is usually caused by some kind of a malignant ulcer or the H. pylori bacteria. And some autoimmune diseases cause a chronic gastritis. But most of us have all experienced an acute gastritis. That's food poisoning or just after ingesting something that's very irritating to our stomach, which causes it to be inflamed. Acute gastritis can just, within a couple of days, your stomach can kind of develop healthy lining, and so the symptoms resolve in a couple of days. So I want to just take a minute and talk about this germ called H. pylori. H. pylori is a gram-negative bacteria. It penetrates the mucosal gel layer of the gastric epithelium. This bacteria is one of the most common causes of a chronic gastritis. Basically what happens in response to this exposure to the H. pylori bacteria, it causes activation of lymphocytes and neutrophils, which causes an inflammatory response, which causes this irritation and inflammation, causing the chronic gastritis. So it's one of the major causes. We will talk about it again in the causes of ulcers, but it's just important to know that it is a bacteria. It is thought to be due to not washing your hands after using the bathroom. It's thought to be passed from, like, it's a contact, so like hand to mouth type thing. So it's on your hands, and then put your hands in your mouth, and that's how the H. pylori gets into the gastrointestinal system. It's also thought, back when they really started kind of identifying H. pylori as a factor in the causes of gastritis and some other stomach problems, that people in rural areas had it more often due to the use of well water. And so that's one common thread that they found, back 1980s, I guess, when they first started identifying H. pylori. So it's kind of an interesting concept, but we will talk about H. pylori again when we talk about ulcers and stomach ulcers and duodenal ulcers and things like that, because it also can be a factor. The important thing to know about, if we identify that H. pylori is a cause of one of these, we need to treat it with antibiotics. So we'll treat them with potentially a proton pump inhibitor, but we will also treat them with antibiotics to kill the H. pylori bacteria. H. pylori, there are some tests that we can do to identify whether a patient has been exposed to H. pylori, which could indicate the cause of their gastritis. It can be done by a non-invasive test in the patient's blood, breath, or stool. The stool and breath tests are considered more accurate. Serologic testing for H. pylori antibodies is the most common method, though. So that's taking a blood test and checking for the presence of H. pylori in the patient. And these are discussed in your book. The urea breath test involves swallowing a capsule, a liquid, or pudding that contains urea with a special common atom. This is all in your book, like I said again. So several non-invasive ways to test for H. pylori. So if someone is showing up with signs and symptoms of a chronic gastritis, we will test them for H. pylori to identify whether or not they have it. If they do, we're going to have to add antibiotics to their treatment. An invasive way to test for this is through an EGD, which is short for esophageal gastroduodenoscopy, which means we take a scope and we look down through the throat and we look down into their stomach. The scope has a little camera on the end of it so that we can see what's going on in there. We can actually take a sample of the tissue and test it for H. pylori. So that would be a very invasive way of doing it. We haven't really talked about EGD yet, but we will. That is an invasive test for looking at the upper GI portion. So we'll talk about that a little bit more as we continue to talk about the esophageal problems and the stomach problems. But it is a camera that we put down through the patient's mouth, through the throat, down through the esophagus. We can look down to about the duodenum, which is the first part of the small intestine. We do numb the throat and we sedate the patient so we don't gag him with the scope. So post-procedure, we have to monitor them for the return of their gag reflex because we numb their throat. And we also want to make sure that they're nice and awake post-procedure before we try to give them any food or a PO intake. So post-procedure, monitoring for return of the gag reflex, keeping their head elevated, and monitoring for their ability to swallow okay after. Patient will often complain of a sore throat for a day or two after an EGD just because of that scope going down through the back of their throat. So these are some interventions that can be done to prevent gastritis, and these are pretty common sense just because we know what causes it, so we need to avoid those things. So avoid, spicy, irritating foods, alcoholic beverages, large doses of aspirin or NSAIDs because they are very irritating to the GI tract. Coffee, caffeinated drinks, same thing. So just try to avoid that and just basically take care of ourselves. Have activity. Try to, maintain a healthy weight. Things like that can help prevent gastritis. These are kind of comparing and contrasting how an acute gastritis and a chronic gastritis would present. So we know that acute is usually that rapid onset of epigastric pain, discomfort, nausea, vomiting, things like that. Chronic gastritis is going to be a little more vague and just be kind of a little less dramatic, but kind of slowly over time. Anorexia due to they'll lose their appetite kind of just because of that constant nagging stomach discomfort, and an intolerance of fatty and spicy foods. Pernicious anemia is an interesting thing because pernicious anemia is essentially a B12 deficiency, so a vitamin B12 deficiency. It's called pernicious anemia instead of vitamin B12 anemia when it is a problem with the absorption in the stomach of B12. So the patient will develop signs and symptoms of pernicious anemia at times with a chronic gastritis because the constant gastritis in the stomach will prevent the proper absorption of B12 from the diet. And we'll explore that a little bit more when we go into anemias and B12 anemias and things like that. Again, I think we talked pretty much about all of this stuff. Health promotion, diet, medications, in the prevention and treatment of a gastritis. Those H2 receptor antagonists can be used because, remember, they decrease that acidic environment in the stomach. So they can be effective in a acute gastritis. Sometimes they can decrease the signs and symptoms of a chronic gastritis as well. So remember, those are drugs like ranitidine, famotidine. You might know them over the counter as Pepcid and Zantac. I'm sure you've seen commercials for them. So again, they're drugs that decrease that release of the acidic content of the stomach. So it just kind of decreases the gastric acid secretions by blocking histamine receptors. There is a great table in your book about peptic ulcer disease that goes through antacids, histamine antagonist blockers, mucosal barrier, fortifiers, your proton pump inhibitors, antimicrobials that are used to treat H. pylori. Those are on page 1131 in your Iggy book. That's a great chart. It's chart 55-4 that you should review for Module 3. Be familiar with those medications in that list. Look at the purpose of the drug, nursing interventions, and the rationales. So basically what we've talked about up until now is basically some irritation to the lining of the upper GI tract. So the esophagus, the stomach, some irritating things that have caused like an upset. Moving on to peptic ulcer disease, we're actually talking about a mucosal lesion. So now the irritation has become more of a lesion, and it's a little bit more serious than what we've talked about in the past. There are 3 types of peptic ulcer disease. So peptic ulcer disease is kind of an umbrella term for 3 types of ulcers. So this is the umbrella for gastric, duodenal, and stress. Gastric is talking about an ulcer that occurs in the stomach. And then the duodenal is talking about that first piece of the small intestine there. Stress ulcers are caused by a patient going through an excessive amount of stress, like a traumatic situation. Sometimes it's a trauma, sometimes it's a surgery. Things like that can cause a stress ulcer, and it's typically gastric when that occurs, and we'll talk about that a little bit more specifically. And I told you we would visit that H. pylori again. So gastric and duodenal ulcers are caused by H. pylori. Most of them are. So this is just kind of a review of what we already talked about H. pylori. It's not certain how it's transmitted, but it is a bacteria. And it's believed to be spread through contaminated food and water. Studies have also suggested that contact with stool, vomit, and sometimes saliva of an infected person can spread the infection. So, and this is just a little visual here to show you that these germs may be through some kind of contaminated water down through the GI tract, and now these little bacteria live in here, causing an inflammatory response that causes damage to the mucosal layer that can actually lead to a gastric or duodenal ulcer. And just to remember, if we identify that H. pylori is present, we have to add an antibiotic to the treatment for this patient. This slide is just focusing in a little bit more on those gastric ulcers, and like I said, that means a ulcer within the stomach. This is the most common area where that would occur, in the antrum of the stomach. And then your duodenal ulcers, that duodenum, that is the first part of the small intestine right off of the stomach. So this is where the duodenal ulcer is, where the gastric ulcer is. They're very similar. Typically, signs and symptoms, it's kind of hard to differentiate, but a lot of times these patients will have pain soon after eating because that food comes down and it starts irritating this. These patients with the duodenal will actually have pain about an hour after eating. because it takes longer for the food to come down and that acid to be secreted to break down the food. So that's kind of how we do differentiate it, that if it's right after eating, it's probably gastric. And if it's duodenal, it's usually an hour after eating, and the pain is usually a little bit lower down in the abdomen is where they'll complain of pain. They're treated very similarly, but you can differentiate it a little bit by just talking to the patients about when their symptoms occur and exactly where. The most common complication of peptic ulcer disease is hemorrhage, perforation. So basically what happens is these ulcerated areas in the GI tract, in the stomach or in the duodenum, will start to bleed, and the patient can have a very serious hemorrhage from the bleeding. It's highly vascular, so the bleeding can actually be life-threatening if not managed well. So we've talked about a lot. If a patient notices, maybe a patient who takes a lot of NSAIDs due to a rheumatoid arthritis, then they're at risk for some GI irritation, which can be an ulcer. So say if they take NSAIDs and drink a lot of alcohol, it could put them at risk for bleeding or developing an ulcer, and that leads to a bleed. And if they develop black tarry stools, that's a sign that there is some bleeding in the GI tract, and we need to investigate it before it becomes so bad that the patient is bleeding to death from a hemorrhage from it. So it's important to identify a bleed, whether it be black tarry stool or if the patient suddenly develops vomiting that appears as coffee ground colored, that is indicative that there is bleeding. Or if it's just frank blood, of course, that they're vomiting, that would be indicative that there is a GI bleed, and we need to identify it early. And probably what we would do is go down with an EGD scope and find the area that's bleeding, find the ulcer that's bleeding, and either clip it off or somehow stop the bleeding, but we got to get in there and stop that bleeding. This patient isn't going to be somebody that we're going to do a barium swallow on, or, they can't tolerate that they're bleeding. So we're going to go in with an EGD scope and try to find that bleed and stop it. That's the best way to treat it. It's important to remember that blood is an irritant to the GI tract. So if there is some bleeding in there, the body's going to naturally try to get rid of it. So they're either going to vomit or they're going to have loose bowels. That's going to be either, there's going to be discolored, either dark or burgundy loose stools, or they're going to be vomiting up coffee ground appearance, emesis, or frank blood. We sometimes will put an NG tube in to help the patient relieve their discomfort and get the drainage out that way, and then we can monitor the output and how much bleeding is occurring and things like that. I pretty much mentioned everything on here on the last slide about the bright blood or coffee ground emesis. It's important to identify that early as something that could turn into something very tragic quickly. The decreased blood pressure would indicate to us that the patient is losing too much blood. The decreased blood pressure, the increased heart rate would indicate that the patient might be going into a hypovolemic shock, which basically means that they've lost so much blood that now their body's trying to compensate for the loss of blood. So that's a very serious situation. So we typically want to try to identify this situation early and get the bleeding stopped, and to transfuse the patient with extra blood if they need it. The following slides are case studies. I believe the answers are found in the comment section, so I encourage you to work through the case study and the questions and try to answer them. This concludes the presentation for the Module 3, Nursing 150, Upper GI presentation. Again, like I said, I encourage you to answer the next few questions in the presentation, and check your answers in the presentation without the voice that is posted, and just to make sure you assess your learning, that you are understanding the content of Module 3.